Right. Hello, everyone. My name is Eddie Qureshi. I'm the founder and CEO of Rainfall Health, an AI-enabled accountability and accessibility software to maximize Medicare reimbursement. For the team model, this is our Rainfall Health team webinar series, and we're helping executives of mandated facilities and systems go from stressed to successful and overwhelmed to over the moon. If you're interested in finding out how your facility may be impacted by the requirements, reach out to one of us, and one of our experts are happy to help. Today, we're joined by Secretary David Shulkin, a healthcare leader whose career has spanned health systems, government care, and cutting-edge medical innovation. Most recently elected the chair of RAIN Advisory Committee as well to help further guide systems on a standardized approach to the team model. Dr. Shulkin, welcome to the Rainfall Health Team webinar series. We'd love for you to jump in and introduce yourself to our audience.
Well, I'm glad to be here, Eddie, and I'm also welcome everyone who's trying to learn more about the team model and what they can do. I'm a physician, I'm an internist, but I've spent my career running healthcare systems. I started my career with what I call my best job, and that was the chief medical officer and chief quality officer of large health systems. I was the CMO and CQO for almost a decade at the University of Pennsylvania Health System, but then served in that role in many other institutions, primarily in the Northeast. I was then CEO of Beth Israel and in New York City, and then of Morristown Medical Center in Northern New Jersey, and did a lot of things in accountable care and other types of models. And then ultimately in 2015, found my way into government when President Obama asked me to lead the veterans healthcare system. And then I remained in government in the Trump administration, the first Trump administration, as his secretary of the Department of Veteran Affairs.
Thank you. Well, you've been chief medical officer, chief quality officer, chief executive, federal leadership, and this new model by Medicare, transforming episode accountability model, affects all of those executives and affects the bottom line in such a tough position in the healthcare ecosystem. What would be your advice to the executives going through this right now?
Well, let's start with that. If you're on the list for team, you have no choice. This is a mandatory model. You were selected. My advice is use that to your advantage. When I served in the chief medical officer, chief quality officer role, I was not the CEO at the time, so I couldn't mandate things. And so my best friend was when things were mandated by government. And that really was a change agent that I used to be able to help the organization prepare for the changing marketplace and the changing reimbursement environment. And so early on in my career, when quality reporting was often looked negatively by physicians because they understood that it was challenging to do risk adjustment, they understood that the data may be used in inappropriate ways by the newspapers or by the general public, quality reporting became mandated by many states. And that was something that I actually said, look, let's use this to our advantage. Let's do the quality reporting better than our competitors. Let's use it in a way to spotlight the areas that we're really good at and to identify the areas that we need to get better at, because that's, of course, what healthcare professionals want to do. So I would say that this team model that's mandatory should be viewed in the same way. While some people say, I wish this would go away, I wish the government, the new administration would drop this model, we have enough going on, it's a challenging enough environment, I'd say you actually should look at it the opposite. We know where healthcare is headed. Medicare has said by 2030, they want 100% of Medicare patients in an accountable, value-based model. We're already in 25. Looking at that type of transition in the next 5 years, we're going to require a lot of change because our systems aren't set up to be accountable in a value-based model. This team model is the way to be able to begin to start educating and bringing your staff along, as well as the hospital administration along, towards a model of both fiscal and clinical accountability. And so you might as well use this as your friend. It's a lot of work, no question about it, but it's what must be done, not only to comply with where healthcare reimbursement's going, but also where we all need healthcare to go, which is to make it more affordable, to make it more accessible, and to make it perform better, because the current system is just essentially unsustainable.
Wow, those are some great insights that this could, instead of being a liability to health systems, it could actually be something that works in their favor and could help push healthcare in forward by leagues. And I love how you talked about the macro level administration goals around making things more accountable as well, and how this does fit into that.
Yeah, let me just sort of highlight it in a little bit of a different way. The question that I get most often when people talk to me is they say, well, you've run hospitals and health systems, but now, as the secretary of the VA, you've run the largest health system in the country. Wasn't it hard to get things done? And I said, no, it's actually the opposite. It was much harder to get things done when I ran a small hospital or when I ran private hospitals. In the government, as secretary, when I wanted to get something done, I would issue a directive, which is a written order, and it would be sent out across the country. And in military-like fashion, because that was the culture, it would get done and implemented. When the secretary put something in writing, a directive, it gets done. And I would sit there in some ways in amazement and say, I can't believe it, that it's actually being done across the country. When I was running a hospital, whether it was in New York City or New Jersey as the CEO, I would sit in my office and I could pound my fist on the table and I'd say, I want to get this done. And as soon as it got out of the office, you could see it get the message getting diluted further and further. The doctors and nurses would say, well, I'm not going to do that. He's not going to stop my paycheck or something like that. So a mandatory program by the government is a powerful tool as a change agent. And absolutely, if you don't agree with the objective of making outcomes better, improving financial performance, accessibility, and affordability, then I can see why you wouldn't want to do this. But if you understand our healthcare system needs to evolve to a value-based system, this is a gift. This is the tool to be able to do it.
Those are some great insights. And, I want to dig into one of the things that you mentioned around the challenges that come up as a system executive that might have multiple sites on the mandated model. For example, we are in talks with one of the larger healthcare systems, which has 16 facilities across multiple states that all have to comply with the model at the site level. What are things that those healthcare executives might need to support them? And do you think having expertise in the rooms as they're creating their approaches might be helpful as well?
Yeah, the way I would approach this running a system is I would look at this as a three-step process. And the time on this, you have to remember, is clicking, because by November, you have to select the track. You have 3 tracks that you can select. Now, if you're not a safety net hospital, you're going to be in the default track 1. But still, it's important to understand your choices. That's by November. But this program goes live January 1st, 2026. It might seem like a long way away, but when you hear all the things that need to be done to be ready, now's the time to be starting this. So there are 3 different ways that I would approach this. Step 1 is I would pull people together to really make sure that you've read through and you understand the model. This is not an easy model. This is complex. It's filled with government language and government requirements. It's a mandatory program. So you better start really taking the time and bringing along your clinical and your administrative leadership to understand what's going on. Now, that will take a little bit of time. And again, finding people who understand how government programs work and interpret this is helpful to be part of that process. But it can be done relatively quickly. And that's the easiest of the three processes. But you can't go to start step 2 and 3 if you don't understand the program. Secondly, the second step will take a little bit of time. And this is where I do think that most systems, most hospitals will benefit from having somebody who understands how to do the second step. And that is really the data analysis. And that's understanding where your organization is now in these 5 surgical procedures from a baseline point of view, but also understanding what your potential downside risk will be financially, what your upside risk is, what your quality metrics are, understanding the way that your systems are capable of reporting out, essentially creating a gap analysis in what you currently have and understanding your baseline, but what you're going to need to have and develop, but also understanding what the impact of this program could be. And it's broader than just your hospital. You're going to have to begin to start understanding this analysis from a entire community ecosystem, because your patients leave the hospital, and this program is a 30-day episode or a 30-day bundle. So you need to begin to start understanding the impact of post-acute care, the impact of home care, the impact of physician services, medications after the surgical procedure itself, after the hospitalization. Again, we don't naturally think that way. Sometimes hospitals have accountable care organizations that have begun to think that way. So there are lessons that sometimes are already known or learned. But this program has specific requirements that I think having some outside expertise to be able to come in and to be able to say, this is the way they're going to look at it. Let's get our own data. Let's do that quickly so we can make some decisions on step number 3. Step number 3 is figuring out the plan to implement. Sometimes systems want to jump right to step 3. I wouldn't suggest doing that without understanding the model and understanding your own data about where you are. But step 3, of course, is figuring out. So we have 5 surgical procedures. We're going to need to figure out a way to align both financial and clinical incentives, because that's what this program is doing with upside and downside, to be able to share financial incentives with physicians, hospitals, other groups. That's the benefit of being part of a program like this. You don't have to worry about the regulatory restrictions in being able to be, share different fees, because you're doing it in the context of a patient, in the context of this government program. And so you're going to have to look at, do we have the care pathways in place? Do we have the ability to report out the quality metrics? How do we actually begin to start impacting the quality metrics that may need to be improved or could be improved? How are we going to do the financial reporting? How are we going to track the results of this and be able to make sure that we aren't surprised at the end? And so one of the questions I might have for you, Eddie, in that you've been spending so much time in understanding this model, talking to different systems across the country that are thinking about this or are beginning to plan for it, is, if you're a typical hospital, what is the potential downside financial risk for this model, especially since so many hospitals are going to be in track 1, which is the capping the financial downside at 10%. And I will say, before I ask you whether you could help hospitals understand this, that the analyses that are done today actuarially suggest that 2/3 of hospitals will lose money significantly on this model. That means that if you're not proactive, if you just allow this model to happen and say, look, we're going to meet the requirements, we're going to do what's necessary to report, but we don't do major change. 2/3 of you are going to lose money. The question is, how much money are they going to lose?
Thanks for bringing me in here. We've been spending, like you said, a lot of time with all these systems, specifically focused on mandated facilities as well. And in that analysis, we are finding that the numbers are not insignificant. Even on track one, they might have exposure that ranges somewhere between 1.5 million and up to 9. And that depends on the number of procedures. There's 29 MSDRG codes, for example, that are on there, the volume of those codes being applied. Uh, all of that matters, but those numbers are not insignificant, especially as we talked about in the current um, financial landscape in healthcare. The numbers actually exceed quite a bit if you look at track three. But as you already alluded to the fact that this is meant to be a risk and reward model. So there is an upside in here for the high performing systems. You are ranked against your other facilities that are doing the same DRG codes in your core business service area. So being a high performance site can be a huge asset and can also help uplift those communities as a whole. And there is a look back period that will determine those target rates. But as you get into track three, which is higher risk and higher reward, you do get up to 20% of your Medicare reimbursement. And that the way the facilities were picked on average have an exposure about 15 and up to 25% of their annual Medicare reimbursement that is now at stake with just these 5 procedures and 29 MSDRG codes.
Yeah. Well, no, thanks. Sometimes it's helpful to have some numbers in mind. So these numbers are significant. I would say sort of two things about it. One is that again, if a hospital or an organization chooses not to deliberately jump into this and control this, they're going to be, in other words, more passive. Those numbers, I think, could actually be much larger on the losses. And again, 2/3 of hospitals, if they do nothing, will be on the loss side. And the reason for that is, we're talking about calculations in the pre-tariff era. Supplies for hospitals, particularly in surgical procedures, are going to go up. Medications, likely, again, rising faster than hospital rates. So we're looking at an environment where reimbursement's going to be challenged, particularly on the Medicaid side of things. And so uncompensated care may go up, but costs are going to go up. So standing still here is not a great option. On the other hand, you also don't want to lose money, not because it's just, a bad thing to lose money, but if you want to actually use this model to your advantage to bring your organization faster towards a value-based model, the very best way is to have financial rewards to share with your partners, your physicians, and your other groups that are part of your ecosystem. If you're losing money, you have no financial rewards to share, and that's going to be a much harder way of keeping people engaged and feeling good about what they're doing. So this is a really big deal that you start out in as strong a position as possible with as strong a plan as possible.
Those are some great points. And I do want to remind our listeners too that even though track one does exist and capture downside, all the mandated facilities are going to eventually be moved to track three, which is the goal for Medicare: higher accountability, greater aligned incentives with the patients, with Medicare, and with the facilities themselves. So not having a plan is not an option. And if, for again, those 2/3 of facilities, it's going to impact them right away. But for all facilities, it will eventually catch up as well.
Yeah, and I think when you look at the distribution of leadership throughout healthcare, those that grab onto this model are going to potentially look back upon it and say, this was our entry into understanding how to drive value-based care. And thank goodness we did that, because if healthcare is moving quickly towards this model, this is going to be that experience, that year or two head start ahead of other people that will position the organization to be successful in the future. And if you're a younger person who's entering healthcare and you have the ability to work on this project, this is the type of foundational experience I think is going to set those people ahead to be prepared to lead healthcare in the future, because this is where healthcare is headed.
Amazing. So lots of great things that can come out of it: growth, alignment of incentives, a better healthcare system, and even financial upside. Um, Thank you so much for joining us. This has been incredibly powerful. Hopefully helps our current mandated facility executives give them more resources to respond to this model. If any of the facilities are interested, please reach out to our team at rainfallhealth.com, and we're happy to help provide personalized financial impact analysis. Secretary Shulkin, thank you so much for joining us today, and we appreciate you coming on to the program. Thank you so much.
Glad to be here. Thanks.